and guest speakers for accepting our invitation and to be with us in this webinar, or you can say it's a conference actually. I'm also glad to be between all of you as an eminent speakers. I want to thank you everyone by himself, Dr. Ahmed Akman, Dr. Ashraf Armia, Dr. Majdi Anis, Dr. Yasin Dawood, and Dr. Razan. And we are going to have Dr. Arthur coming, and also we are going to have Dr. Safwan Al-Bayati with us. I will be moderating this session if you allow me, and Dr. Majdi and Dr. Razan, they will be a co-moderators. And I think our session, it will start now. And I think I will start by Dr. Ahmed. Please, if you can go ahead, please, Dr. Ahmed. Thank you very much.
Welcome, everybody. Thanks for nice invitation, Mohammed Al-Amri. It's a great pleasure to be here. You worked very hard to make this happen. And I think it will be a great conference today.
Thank you very much.
I will start to share my screen.
Yes, go ahead, please.
So I think you can see it now, as I can see if it is working. I will talk about the FLACS, the state-of-the-art surgery, the femtolaser-assisted cataract surgery. Our objective is to discuss the role of femtolaser-assisted cataract surgery in current practice. These are my financial disclosures. Femtosecond laser-assisted cataract surgery was first used in 2001. It was previously used for refractive surgery. It evolved for cataract surgery in time. And I will talk about my experience about 700 cases, which I have done between 2015 and 2018. Femtosecond laser-assisted cataract surgery represents an important technological advance in ophthalmic surgery. Better visual results are expected with FLACS due to less IOL tilt, better IOL centration, possibly less endothelial damage, less macular edema, and less posterior capsular opacification. You can see that femtosecond is, I can say 10⁻⁻15 seconds, a very, very, very short time. So we don't have collateral thermal damage. It's very precise. It has a deep effect. And a lot of companies are making femtosecond lasers. And currently, as far as I know, around 6 different companies are still manufacturing femtosecond lasers for cataract surgery. So what can we do with femtolaser in cataract surgery? These are corneal incisions, astigmatic keratotomy, capsulotomy, and nucleus fragmentation. For corneal incision, we can use different techniques, and with these, we have an incision that can be planned with 3D architecture. It will be standard all the time, can be planned on any axis, but I found in my experience it's sometimes difficult to open or close these incisions as they are not continuous incisions like the ones we make with a blade. The second thing is femtosecond laser-assisted keratotomy. This is effective for astigmatism less than 1 diopters. It makes standardization possible. Toric IOLs would be better in astigmatism, which is over 1 diopters. And toric IOLs generally cost less than femtolaser PIs, which are quite expensive in my country. It can be planned on any axis, and the surgeon can choose to open the incision at the slip length on the day after the surgery, so it can be possible to titrate the results. Femtosecond capsulotomy was the main feature of this technology in the early days. You can have a well-centered, symmetrical, and standard capsulotomy. It's more important for premium lenses. The problem is it may not be as strong as the manual capsular axis. And you see in these pictures from these different lasers, in the manual you have a continuous capsular axis. Instead, with the femto laser, you have like dots coming together and making a capsular axis. The final thing we can do with the femto laser was nucleus fragmentation. You can choose different methods. This one was from my early days. I was trying to make a nucleus as liquid as possible, so using a lot of circular cuts. The aim was to decrease the phaco energy, aim also to make the nucleus removal easier. Different patterns was possible, and gas generation can be a problem. So, at the end of the day, and after doing hundreds of cases, our question to each of us in our clinic was, is there any real benefit of femtolaser cataract surgery? People against it say all the steps can be done manually, but the femtosecond only aims for standardization. Also, new alternatives for capsulotomy and nucleus fragmentation became available after femtoseconds, like zeptocapsulotomy, which gives us a really perfect circular capsular axis, or like capsule laser, which is also a very good capsulotomy method with very high strength capsular axis edge. Also for the hard lenses, the MyLoop device became available that can cut the hard nucleus in 2 or 4 pieces. So our expectations from femtolaser assisted cataract surgery, which was lower phacoemulsification power requirements for less endothelial cell loss and less postoperative corneal edema, and more predictable refractive outcomes, more precise anterior capsulotomy, and less postoperative lens decentration and tilt. So, is FLACS really better? The biggest problem is the cost. The device is very expensive, and the personal interface, the PIs, which I used with the Alcon device, was quite expensive. Is it better than manual? Is refractive and visual results were better? Is there less complications? Is it better for a special type of patients? And what will be the future? For the cost, it's quite a high cost, so I don't like it. Is it better than manual? We will see it in few slides. Also, for some kind of cataracts, probably it's better than the manual. We did quite a lot of studies, and we published them in and presented them in European and American cataract refractive surgery meetings. The first one was the comparison of mean phaco energy with femtosecond laser assisted cataract surgery and conventional one. We didn't find a very big difference. In another study, we compared the visual and refractive outcomes, and although the difference in mean absolute errors was small and insignificant, it's a little bit better with the femtosecond laser. In another study, again, the results are quite the same between manual and femtosecond lasers. The correlation between cumulative dissipated energy values and lens thickness in femtolaser assisted cataract surgery was also, there was not a big difference between the manual and the femtolaser. In the literature, there are some big studies like this one from Manning and the group. And they say that femtolaser assisted cataract surgery did not yield better visual or refractive outcomes than conventional cataract surgery. Intraoperative complications were similar and low in both groups. And postoperative complications were lower in conventional phaco surgery. I think this because of there is a learning curve, and I had few complications in in the early cases also. Also, this is from the Lancet. It's a very big study published this year, and I think it's important. They studied a big number of patients, and their interpretation was, despite its advanced technology, femto laser was not superior to phacoemulsification in cataract surgery, and with higher cost did not provide any additional benefits over classical one for the healthcare systems. I want to give some of my pearls from my previous surgeries. Let's start the video. As you see, during the cataract surgery, I try to leave a safety zone. You can see on the screen that in this area, we have the safety zone. And we check the capsular axis very carefully, because sometimes there are some areas which is not cut by the laser, and it can be a reason for the problems during the surgery. You will have anterior capsular tears. As I said, these are from my early days. I try to make as much as the nucleus softer, so I was using this much of rings in the center. And in the later years, I decreased it to the 2 circles. You see the gas bubble formation. And this is how you see in the operating room. This is the important part. You must be sure it's free floating. Sometimes there are capsular tags. You have to check it. And if there are tags, you have to turn them like going around with a new capsular axis in that area. Otherwise, you will have anterior tears, and it will be a very big problem with the nucleus still inside of the eye. For the hydrodissection, you must do this one. You must press over the nucleus and take out the bubble. Otherwise, you will have an open posterior capsule because of the pressure caused by the gas bubble. Just a little amount of fluid for hydrodissection. Let's see. And press to the nucleus to take out the gas bubble. This is a very important part of the surgery. Another case. And this is the nuclear removal. You have to try to turn the nucleus a little bit with the hydrodissection. Otherwise, it will be difficult to take out the parts. You see how big is the gas bubble behind the lens. For me, the nucleus removal is one of the easier parts. Generally, you just try to chop it and it's already cut to the pieces. So when you hold it, it's easy to chop without much pressure or much effort. At first, I take the area in the center so I can hold the pieces easily. You can cut it to 6 or 4. I prefer 6 cuts. A little bit fast forwarding. Again, when you take out the first part, then it will be very easy to take the other parts. This is the tricky part, which you have to use the bimanual one, and you have a 300 micron cortex, which quite firmly attached to the capsular axis edge due to laser damage there. So I was using coaxial irrigation aspiration in all my practice. During the femto time, I have to change my irrigation aspiration to the bimanual one. You can do it with the coaxial. As you see, I all the time use the polymer tip ones, which you are doing premium surgery and you don't want to have any kind of capsular tears during irrigation aspiration. And I think in this patient, you see it's not very easy. And during, I catch the posterior capsule at the moment. Here you see the capsule is there, but with the polymer tip, you can just leave it back and you don't have a capsular tear. Probably it was a metal one that can open the capsule. And in my experience, it's a wonderful technology for cataract surgery, but the cost is really, really a big problem. It costs maybe 5-6 times than a standard IOL, and it costs nearly to the price of a premium IOL. Results are not better than manual phaco in the hands of experienced surgeons. I think it's the most important phrase, because in the hands of an experienced surgeon, you do a very good capsulotomy, and it nearly looks like a femtocapsulotomy. Femto can help novice surgeons more, but as it's a very expensive technology, it's not easy for the novice surgeons or the residents to use it in their daily life. So it can be the reasons for, in many studies, we can't show the better results of FLACS because it's the experienced surgeons have really good manual results. It can also, it needs further development. For me, I would like to change the parameters more, more laser for harder nuclei, less for the softer nuclei. So I think there is still need for development. I think there will be not very common to use this one because of the cost in the future, but it will not go away from the refractive surgery. Thank you for your attendance and your attention. Thank you very much.
Thank you very much, Dr. Ahmed. Excellent presentation. Let me ask here, we are having many experts also, if they are having different opinion or same opinion about the using a femto cataract surgery. Let's start with Dr. Yasin. Are using? Yes, Dr. Yasin. Can you share with us your experience?
Yes, I actually, thank you so much for sharing these beautiful pearls. And I think these are really, really important for beginning surgeons. And thank you for the beautiful videos.
Dr. Ahmed, can you please just stop share, please?
At the moment, I stopped the share.
I think it's probably me that is sharing.
Ah, this is you. Okay, sorry. Okay, Dr. Yasin, go ahead. Sorry,
so one of the things is I actually published a couple papers where we did fellow eye comparison of femtosecond versus conventional. And I very much agree with Dr. Ahmed. We published those in the British Journal of Ophthalmology last year. And we really had one eye femto, one eye phaco. And I agree with you. We had no difference whatsoever in the outcome, whether it is refractive, whether endothelial cell density. The only difference was it was a little bit longer OR time and a little bit higher expense and more IA time with a little bit more fluids into the eye. With a little bit more cell loss, but not a whole lot. Overall, I think it's a great technology. I use it for patients who have significant zonulopathy because it really does help with the capsulotomy. I use it with some patients who may have a little bit of corneal opacity because it actually does go through the capsular opacity. Through the corneal opacity. But for a routine cataract surgery patient, I have not found it to be any better than what I do manually. So
thank you, Dr. Yasin. Thanks a lot. Dr. Ashraf?
Yes, thanks, Dr. Ahmed, for the presentation. I'm using the femto cataract maybe since 6 years in our hospital, but now I'm customizing using only for difficult cases like some zoniolysis. If you're putting a premium IOL, you need a more centration of the IOL. Or sometimes now I just published a case presentation about using the FLACS in congenital coloboma cases, and I followed the patient for 4 years now, and with no anterior posterior opacification and well-centered IOL. So are you modified using this technology now in certain cases, not all the cases?
Thank you, Dr. Ashraf, and thanks, Dr. Ahmed, for a comprehensive and let's say honest talking about this technology. Thank you very much. And now we will have Dr. Yasin Dawood. Dr. Yasin Dawood is a cataract and refractive surgeon. And he is going to talk about optimizing toric IOL outcome. Dr. Yasin.
Thank you so much, esteemed colleagues and friends. It's really wonderful to see some of you again virtually. Wish that we were together in person, but with the circumstances. I'm going to be talking about outcomes of optimizing outcomes of toric IOLs. Toric IOLs is something that I actually really believe in, and I think it's a fantastic technology. It's a great technology, but it also has a little bit of shortcomings. So we have to understand what would be the best thing for our patients. What do we have to do in order to ensure really good outcomes? I would highly encourage our audience to basically, we published this paper a while ago, a comprehensive guide to managing astigmatism in the cataract patient. This will go through over some of the topics that I'll be talking about today. So when we look at astigmatism, you have to recognize, is that my astigmatism regular? Is my astigmatism irregular? Is it with the rule like above? Is it against the rule? And these things just for us as ophthalmologists become secondhand nature, but that really is important. What kind of astigmatism am I correcting? How much of the astigmatism am I correcting? Why is astigmatism correction important? If you look, by the time you have 2 diopters of astigmatism, the quality of your vision has significantly deteriorated. And thus, really, to improve the quality of the vision and the quality of the life of the patient, this has to be corrected. It can be, of course, corrected surgically, or it can be corrected with the glasses. But this shows us a little bit of what the patients experience. How prevalent is astigmatism? Basically, you have about 40% of the patients have 1 diopter of astigmatism or more, and about 20% have more than 1.5 diopters of astigmatism. When that translates to vision, you see that at 1 meter, about 20, 40 or so, if you have 1 diopter of astigmatism, and it really goes down significantly by the time you get 2 diopters of astigmatism right here. Is it cost effective? In the United States, it is very cost effective. Actually, this was published by my good friend Roberto Pineda from Mass Eye in Archives of Ophthalmology. This is 2010, where they showed if you are 7 years or younger in the United States, having a toric IOL is actually less expensive over your lifetime. So what lenses do we have available? In the United States, we have 4, but overseas, you guys are a little bit more lucky than we are, in the sense you have a little bit more array. Most of our lenses correct somewhere between 1 to 6 diopters of astigmatism, but overseas you can custom make it to correct about 1 to 15 diopters of astigmatism. So you really can go high up. Of course, the possibility of somebody having 15 diopters of astigmatism, you have to realize, is this really pathological or something else? Why does this patient have that much? In the United States, we have the Alcon Acrysoft IQ Toric, and it comes from T3 to T9. Very important for the beginning surgeon. When you actually look at the IOL, it says it corrects 1.5 diopters, but that is actually at the IOL plane. On the cornea plane, it actually corrects 1.03 diopters. And all of these lenses, they basically go up, typically with about 0.5 diopters at the IOL plane, but 0.75 diopters on the cornea plane, about 0.75 diopters at the IOL plane. It goes up to our T9. We have the STARS Nano Flex Toric lens, we have the AMO Technos Toric lens, and we have the BNL True Line Toric, which is based on the Crystal lens. Now, all of the companies now in the United States do have multifocal toric lenses as well. How do I ensure to have good outcomes? Number one, what I do is that I measure with actually 3 modes of measurement of what lens, and well, the lens, the actual length, that will be taken care of by my IOL master, but at least the 3 modes of measurements of my of the cornea, and I'll come to that in a second. And these modes of measurements have to utilize different kinds of techniques so that it is very consistent with that. Number 2, on the chair from the very beginning, I tell the patient, after I talk about the risks and the benefits of the cataract surgery, I tell them regarding this lens, I say, look, this lens is made from the same company by the same material, so it really does not affect the risk of the surgery, but the goal of this lens is minimize the need of glasses. And I have had a lot more happy patients when I tell them the goal is minimize, rather than a lot of the people in the community would say, oh, this will eliminate your need of glasses, which is not necessarily true, and we will look at the data. Which patients do I exclude? If you have any zonular weakness, and I have a plethora of those patients, or capsular dehiscence, you really are not that great, because you want the lens to be right on the axis. It needs to be centered in order for you to get the correction. If it is not, you're asking for trouble later. Those are, for me, absolute contraindications. Now, relative contraindications is ectasia, even though I've actually done it in about 20-some patients with really good success, and we're publishing that paper soon. Corneal scars, it depends. If it is multifocal cornea, no, but if the corneal scar is very focal and you don't plan on removing it and whatnot, maybe. Poor pupil dilation, just because as long as you can actually see the 3 dots or the 2 dots, depending on the IOLs that you use, where the astigmatism axis is, you're fine. But if you can't, you probably should not put it in. Prior surgeries, and I'll come to a study that we just published recently. Very, very important. As I tell all of my fellows and my trainees, junk in, junk out. Good calculations in, you're hoping for best outcome. So preoperative measurements, you have to be very careful with the preoperative measurements. Then you have to be very careful with the perioperative measurements. You have to understand what the posterior cornea does, and then what would happen if you have posterior postoperative IOL rotation. So let us start with the preoperative. Number 1, measurement of corneal astigmatism. Depending, I have at the Wilmer Eye Institute at Johns Hopkins, I see patients in a couple of places. We have some people who still do really good manual keratometry. Most of the time, what I actually use is the IOL master, and I use the Pentacam by now, the corneal topography. But you can use the placido disc and whatnot, and an autorefractor. Those are the 3 that I routinely do for any toric patients. If you look at the posterior cornea, you look at it, there are a few techniques that do not take the posterior corneal curvature into effect, but the LensStar, the IOL master, which I have, it doesn't. So I actually rely on the Pentacam. If you have the Orb Scan, it would. If you have the LensStar, it would. Of course, you know, the eye trace and the aura, all of these do take the posterior cornea into calculation. Why is the posterior cornea important? When we look at the population, 51% are actually of us are steep vertically with the rule. Posteriorly, though, 87% are also steep vertically. This is a little bit of gymnastics. The problem with the posterior cornea is the fact it's actually a negative lens. So if it is a steep vertically, what it would do is that it actually creates a plus power at the horizontal meridian. And that's why you have to take it into effect, because it really causes against the rule ocular astigmatism. So if you do not take that into account, your patients may end up having against the rule ocular astigmatism afterwards. Many of the lenses, basically, any of the lens companies that make these, they have their own calculators, and you just have to put your name and the patient and what kind of lens you want. If you use the Barrett on the Alcon, it usually takes actually posterior cornea into effect. It has its own correction factor, as well as the effective lens position in these patients. The Tecnis IOL, you actually have to click this in order for it to include posterior corneal astigmatism for you when you're doing your calculations. The Holiday will do that for you as well, and the TrueLine. The most important thing actually in all of these calculators is a human error. I have had a patient that was referred to me with a 3.25 diopters of astigmatism, and when they transcribed it, they unfortunately did it from 0.15 to 1.05, and that was just the perfect 90 degrees away. So instead of minimizing the astigmatism, it unfortunately doubled the astigmatism, and I had to rotate that lens. So human input error. The IOL master, actually, if you want, it actually does give you on the Barrett toric calculator now, it's available. It tells you what lens you want. It depends on what lens you choose. It tells you what T you want to have, what power, and it tells you where and how much your refractive predictive error, as well as residual astigmatism. So for me, this is something that is readily available. I don't have to have my fellow calculate these lenses and for me to double check it. So this is one way to get over human error. Perioperatively, all of us by now should know the fact that when we actually sit down, when we go from sitting to lying down, our eyes cyclorotate, and the mean rotation is about 4 degrees. However, 8% of patients actually of eyes rotate more than 10 degrees. Why is this important? For every degree of cyclorotation or being off axis, you lose 3% of the power. And that means if you are 10 degrees off, you have lost about a third of the astigmatism correcting power. For lower astigmatism correcting lenses, for lower powers, that may not be that important. But if you are really putting, a lens that corrects 4 diopters or so, all of a sudden you are 1.5 diopters off of your astigmatism correction. So this is really, really important to do that. This is a picture of my fellow about 10 years ago. And you can see that my fellow is actually marking the patient on the day of surgery. Unfortunately, they are giving the patient about 40 diopters of astigmatism because there's so much pressure. You do not need to apply that much pressure. There is the ASICO electronic toric marker, and that actually balances so that you are flat with the ground, and it gives you the green light when it does. My favorite one is the robo marker because it's gyroscopic. So whichever way you rotate your hand, this you actually do it in the preoperative area. You also put the axis. You do not have to do it pre-op and intra-op. So it's just one-time deal. It lasts for about 2 hours. The intraoperative imaging assistance with Aura, iTrace, or the hollows do have a little bit better outcome than the manual marking. And if you are lucky to have one of these Aura, for example, it will actually tell you when you put the lens, okay, maybe you need to rotate it either clockwise or counterclockwise. And then once you actually do it, then it will tell you no rotation recommended, which means you are done. The Aura does that. Why is Aura slightly better? It's in astigmatism correction. If without Aura, about 23% of patients are outside of 0.5 diopters of target refraction. If you do use the Aura, it's about only 10% are outside. So you really are having about 50% improvement. In patients who have had refractive surgery, you see the same level of improvement as well. Callisto will get you image of the eye translated to the size optim, that Lumira 700, which I have in the OR, and that will tell you actually where the axis is based on the iris and based on the eye topographies. The hollows give you also the axis, but it doesn't tell you where to put the lens. It just tells you where the astigmatism is, and the True Vision will do the same thing for you. Now you have done the surgery, you have done everything. What do you do? And what kind of lenses do you choose? The post-op, really, all of your outcomes are going to be based on how did you mark the patient? Were you good with the marking? What lens type? The hydrophobic acrylic lenses tend to be a little bit more stable and don't rotate as much. Very important, when you're actually operating your capsular rhexis size, you should have a little bit of IOL coverage so that you have a little bit more contact between the capsule and the IOL so the lens does not rotate. When you look at the outcome of these lenses, it's actually pretty respectable. When you look at better than 20/40, about 92 to 95% with the AcrySoft toric, and with the other one that is most common in the United States after the toric is the Technis, it's about 93%. They see 20/40 or better. Within 1 diopter of refraction, practically about 100% of the patients in the studies that have been published. So what are the errors that you'll be looking for is, did I put the axis correctly? Did I measure the axis correctly? Did I align it intraoperatively? And if I did, what happened to the lens afterwards? I had one patient of mine, and once you have it, you'll never have it again. The nurse said, okay, here's the axis. And I always put actually the toric IOL calculator right next to my microscope, so I know where my axis is. And she said something, and as I'm ready to basically take the drapes off, I remember that doesn't sound right. So I look, and we had to re-drape the patient and rotate the lens. So if it's very, very important for you to not only mark the patient beforehand, but really make sure in the operation that you have the correct axis. With the robo marker, we don't have that issue anymore. I know that my good friend is following me soon, and he will be actually talking to you about how to manage residual refractive error if there is a problem after your surgery. So I'm not going to talk about that. There was one study that we recently actually published in the Journal of Refractive Surgery regarding toric lenses, not in routine eyes, but actually in eyes who have had previous ocular surgeries like penetrating keratoplasty, glaucoma, scleral buckle, corneal refractive surgery, and RK surgery. This is a patient who has had RK, and she has residual 3.31 diopters of astigmatism in the left eye. You see that she has a slightly multifocal cornea. I was really hesitant actually in this patient to put toric lenses because she has 16 RK incisions. I wasn't even sure whether the RK is going to be stable, whether the RK incisions are going to open up and stability. And we talked about it, but she was adamant that's what she wanted. And I was like, look, if I do it, you have to be ready that I may have to do an IOL exchange. You can see that on the right eye, I'm having a hard time actually even positioning because, you know, I can't go in except that I have to go through some of her RK incisions. I have done quite a bit of these, and I'm able to manipulate my incisions where I don't have to open it. You'll see that I have already finished in this case, and I have marked it on her axis. You'll see that actually a little bit of the RK incisions open up with just a little bit of hydration right here, and you can see the opening. She actually fluctuated a little bit, but by post-op month 1, she was 20/30 in this case. So you have to pick your battles, you have to pick your patients very well. What did we find? In this patient population, we had 133 eyes that we actually reported on. The uncorrected visual acuity beforehand was 0.73 logMAR. At month 3, actually, we had about 20/30 mean uncorrected visual acuity. Best corrected visual acuity in this patient population was about 20/25. When you compare that to the controls, you will see that the patients who have had a previous surgery actually performed as well as the controls, as patients who did not have previous surgery. When you look at our outcomes with refractive predictive error, at basically how many patients are within 1 diopter at month 3 to month 12, you find that 88.4% of the patients were within less than 1 diopter. When you look at the astigmatism, 84.4% were also within 1 diopter, and about 54% were within 0.5 diopters. So these patients actually end up doing very well despite having previous surgeries. I tell the patients that, you know, considering the fact that you have had a previous surgery, I'm not as sure about your outcome. You have to be ready for potentially fine-tuning. I'll leave that to my good friend who's following me soon so that he can tell us about it. So Arthur, I will give you the stage very soon. Thank you, guys. I'm happy to take your questions.
Thank you, Dr. Yassin. Thank you very much for this very illustrative talk. But I want to ask Dr. Safwan, how many % of your patients you are using toric lenses, please?
Well,
and I want to ask,
I just need to thank Dr. Yassin for this nice presentation. And there was in my mind just to ask him a few questions, but with my comments, I will ask him. Well, actually, more than 35% of our work now it's with the toric. The issues is that what I'm doing is that it's not far away from what Yassin said, but I'm using the K reading of the total corneal power that taking it, and then using it through a Barrett. And I found that the best result that I've got and the axis of the total corneal power, I'm using it also in this way. And definitely, as Yassin said, we are using a lot of measures. For example, I'm using the Cyrus, Pentacam, Varian, and the IOL Master, and the latest one, the latest generation. So from this K values as a mean, and the K value for the calculation of the sphere is not the total, but the K value for the toricity is the total K. And the total K, when we are using it in the Barrett, I got the best result that makes more than 90% of my patient within a plus minus 0.5, and from the targets that we are targeting.
Thank you, Dr. Safwan. Dr. Ahmed, are you the same, online the same, doing the same? No, can you unmute, please? Doctor, can you unmute, please?
Sorry. Dr. Safwan said the correct thing. We try to use the total corneal power for the spherical calculations. No, and I also discussed with Dr. Warren Hill. And we start to have some more error with the spherical part of the biometry. So we must tell people not to use it for the spherical calculation, because none of the formulas are written for total.
That's right. Correct. Exactly. So the total corneal power is only for the toricity.
That's exactly
Yes.
right. So if you're going to use the total corneal power, you're really using it for the toricity and the astigmatism axis, but you're not really talking about the spherical equivalent of the
Yes,
IOL, which
exactly.
should come really from your from whatever you're using, either IOL.
Yeah,
That's right,
that will be my presentation. So I will in details showing all the details.
Okay, we will not talk about this point.
Yeah, yeah.
May I ask a question?
Yeah, please.
What do you think, all of the panel? There was an interesting lawsuit against one of my colleagues in Turkey. The patient sued the surgeon for not using the toric lens. So do you think not using the toric lens is a malpractice? Because in the government health system, there is no toric lenses, and even patient want to pay it, he must go and take it, and it's a big burden. So most of the doctors did not say to the patient there's something like that, but he had the lawsuit because of it. How is it in US?
Yeah, I think no. I think the
people-
patient has to be honest. The doctor has to be honest with the patient. He has to tell him that he is in need of another kind of lenses, which it's not available with us.
Yeah.
And he has to choose the patient. The patient has to be, if he wants to pay, he can go to the private sector, or if he will accept, and he will tell him the difference. I think this is the doctor's job.
Now they put this close to the paper that patient signs that we offered him toric lens, but he didn't accept. So it's now on the papers
On the
that
written
patient
consent.
signed.
So
Yeah,
it means that
on the consent.
it's written in the consent.
Yes.
So Dr. Ahmed, in America, we sue for everything, right? So, but this is the first time I have served as an expert witness on many of the IOL because I deal with a lot of the complex and the complications kind of thing.
Thank you, Dr. Yassine. Thank you very much.
Actually, what we have to do, I'm sorry, I was just finished. In order for us to put a toric lens, if somebody is Medicare, we actually have to make them sign a consent that it's okay with them, that because Medicare doesn't pay for it. So we have the opposite problem.
Dr. Muhammad, can we start another?
I'm gonna stop sharing my screen. Go ahead, please.
Thank you, Dr. Yassine.
Now, Dr. Arthur should be ready.
Yep. Hi there. Good day, everyone.
Hi,
Thanks for
Dr.
the nice
Arthur.
Hello there. How are you?
I'm fine.
Hey, Arthur.
Hi, Yassine. Nice talk, and I'm glad I'm following yours, so I know exactly what's been said. So I'm going to be speaking about the management of post-operative toric IOL residual astigmatism. So patients paid the extra premium, they want their astigmatism corrected, and they find out afterwards it's not corrected. How do you manage it? These are my financial disclosures. So I think we use the eye trace to do this, and what the eye trace does is it really helps us instill confidence when patients are unhappy. So if a patient's not happy following their surgery, the first thing to do is to empathize and say to them, don't worry, we'll get to the bottom of this. We can sort this out. It's not the end of the story. You take the patient to the eye trace, put a few drops in to make sure the surface is good, and then you use their data and their simulations to separate the corneal versus the lens aberrations. You'll also assess tilt. I'll show you how that looks in a moment. A recent study by Rupert Menopar showed some interesting things about toric stability. And the first one is that if a toric IOL is going to rotate, it's going to rotate within the first hour and on average 5 to 6 degrees. And the best time to measure it is at 2 weeks. The best way to measure is with the eye trace toric check. The best time to rotate the lens is within 2 to 4 weeks from the time it was done. And his suggestion is don't use a viscoelastic when rotating, and only open the leaves of the capsule where the haptics are currently placed and where they need to go, not for the entire way around, because then they can move around again. So just open up the zone where you know there might be, where you want them to move. So I'm going to show you a couple of cases. Here's the first case, where the simply toric IOL, young 48-year-old patient seeking relief for presbyopia, has significant astigmatism, so decided on a toric, and this clear lens extraction was planned with a simply toric, and the results were poor post-operatively. So the patient's unhappy and was sent to us for a consult complaining of their dysphotopsia. So the first thing you do with the eye trace is acquire good, reliable data on corneal topography and the wavefront, compare several measurements to ensure the data is reliable, look at the manifest versus the eye trace refraction, locate the source and the type of the higher order aberrations, assess the optical alignment of the lens by using the eye trace on the dilated eye, the radial ruler to confirm the optical center of the lens, and then use the toric check to assess both alignment and cylinder power versus corneal power. So this is an example of just looking at a couple of topographies. They look alike. The difference map is there's no difference. So you know your corneal data is accurate. You're doing the same thing now with the wavefront data. This is really giving you an idea of the internal optics. So in fact, you are now seeing your toric IOL. And now you're going to look at the refraction that the Tracy found with astigmatism of 118 at 82, and your manifest refraction is 1 at 80. So you know the data is solid, there's good readings, the refraction matches. So you can now use the eye trace to help you make the decision. This is the patient leading into surgery, and the astigmatism is 128 at 83. The eye trace then, you can also look at other aberrations. That's not part of the discussion for now, but you can look at the other aberrations. And what the eye trace now says is, well, the internal optics are aligned at 110. The corneal optics are aligned at 139. So in fact, this lens needs to rotate by 29 degrees clockwise. And that should then give you a change of 1 diopter power in the cylinder. And you should go from 1.3 astigmatism at 83 to basically 0.23 at 138. So that's what you're meant to do, going to rotate this lens. You can also use the eye trace to help you decide on how big your angle alpha is and so forth. And you can even see things like lens tilt. But the topic at the moment is mostly about toricity. So what a toric rotation shows you is it shows you whether the cylinder is correct, but the alignment is not for the previous patient. The cylinder power that was chosen was correct, it's just it's not properly aligned. Now, of course, there might still be dysphotopsia afterwards if there are other issues with the lens. The very large angle alpha might contribute to that and might have been a contraindication in some minds. And then toric lenses can sometimes move, and they are more forgiving when there's a larger optical zone, but you can't overcome big alignment errors. There's another patient also with a symphony, 47-year-old with a refractive lens exchange, and you can see again the misalignment. Internal optics of 140, external optics of 102. The lens needs to rotate by 38. Now, the current astigmatism is 3.87 at 82 degrees, while the predicted post-rotation refraction is going to be 0.99 at 102 degrees. So now you know that even if I rotate this lens to the best position possible, I'm still going to have residual astigmatism. And that's a very good time to think about rather doing a PRK. So the PRK was done, and this showed now that once the eye trace was done, that if you went and corrected now, you'd rotate the lens by 7 degrees to get it perfect, and you would still have it. It wouldn't really make much of a difference to your final outcome. There's another case with 2.75 diopters of astigmatism at 95, planned treatment, an RLE with toric implantation at T9. We always look at 4 devices. So here's the lens star, here's a shine fluid, there's a Placido disc, and we'd also take the MOVA or one of the others. And here's the eye trace saying that the astigmatism is 4.60 at 90. So a lot of agreement on where the astigmatism is. This goes and shows us now clearly the lens is currently on this axis in gold, but it needs to rotate 38 degrees clockwise. The second scan says it's 39, and if you repeat these scans, they'll come up, they're pretty predictable. So the eye trace is a wonderful tool to tell you what to do in terms of rotating. So rotate the lens 38 degrees clockwise, and now you find you're on target, be 1 degree off, but the refraction is as good as you can get it. So there are 2 scenarios basically. The one is that your toric IOL is correct in terms of power, but it's misaligned. The treatment then is rotate the lens. The next one is that your toric IOL is incorrect in terms of the toric power, and it's also misaligned. And then your treatment must be via PRK or LASIK or incisional surgery. And the lasers today, I'm not going to spend much time on this. We're all familiar with the lasers, but they give us a lot of power in both the excimer component as well as the femto. And when you're doing a toric, you can also sometimes ask yourself, is this patient better off with a toric because this astigmatism is slightly irregular? Wouldn't I just be better off from the word go doing a non-toric and then correcting the astigmatism with a laser? So it's a question to ask. And same thing on the pentacam. Is it really symmetrical? No, it's not, because the steepest point isn't central. It's actually quite inferior. So the way we can do it today is with a femto, we can make flaps that accommodate astigmatism. They're oval in shape. It can actually show you where the ablation profile is going to be. And you can place the ablation profile on the cornea, and you can see once the femto is created, it's exactly what the flap looks like. And then the additional power you have is you can also decenter your flap slightly to accommodate pupil-centric shift. And then you can see the LASIK done and the treatment placed on axis. And then the FS200 also offers us power now in terms of corneal incisions. And these corneal incisions with LRIs can either be through the epithelium or can be intrastromal. And they can either be, the laser will normally default to two opposite incisions that are hooked, and you can move them around. But if you have an irregular cornea, you can actually, like a cornea like this, instead of having the two at the same point, you can actually disassociate them. I'll show you now in a second. So these are always going to be 180 degrees fixed, but you can go and dissociate them, and now you can place these wherever you like. They don't have to be 180 degrees apart. If you like, you can even switch the one incision off. So the femtos and the EX5 or the excimer have given us another tool to really help us deal with residual astigmatism. And on the FS200 at the moment, it even has cyclorotational tracking, as does the EX. So the eye trace value in the clinic for me is it has the ability to demonstrate issues to the patient. The patient can understand why they're not doing well. We can separate cornea from intraocular issues. It helps us a lot when to do a corneal approach rather than a lens approach. It shows the effect of dry eyes very clearly, and it helps with toric IOLs and their post-operative management. Thank you very much.
Thank you, Dr. Arthur. Thanks a lot. Safwan, I think you are unmute. You want to ask Dr. but you are, can you unmute yourself? Yes, please. Yeah. Now, Dr. Safwan.
Okay.
You want to ask Dr. Arthur?
Well, there is a few questions, but while I'm presenting, because all our presentation from Dr. Yassin to Arthur to me, it was related to the calculation of the lens. So I think that through which I will go to Dr. Arthur a few things to decide that eye trace is the best tools for re-estimate the residual astigmatism in the lens, but a few issues that we need to mention it while I'm presenting, so just saving the time. So I'm sharing
no. Dr. Safwan, I'm saying if you have a question to Dr. Arthur, any question for Dr. Arthur from any of our colleagues here, Dr. Yassin, Ahmed, or Dr. Ashraf?
Yes,
I have one question. Yeah, sorry. Yeah, go ahead.
No, that was a great presentation as always. Learn a lot from you whenever you present. I have had a patient actually of mine that I literally just saw her now.
Dr. Yassin, can you raise your voice a little bit so it can be clear and ask directly, because we know time is very short, sorry.
Sure. The question is, if somebody does have multifocal toric and they are still having some residual astigmatism, or you know that their angle alpha is a little bit off, would you still rotate, or would you actually just take the lens out?
I think that's a great question. I think what I would do is I'd probably, due to the fact that rotation's relatively speaking so simple compared to a lens exchange, I'd probably first rotate if the eye trace suggested we get close enough to emmetropia, and then try that first and see how it goes. You know, I haven't had it in my own experience, but I've seen it and heard about it too often, that people do a lens exchange and then the patient's really unhappy and says, I want the multifocal back again. You know, so I think I'd first play very conservatively and take it step for step.
Yeah.
Okay, any other questions? Dr. Ashraf, I think you have something in your mind.
Yes, Dr. Arthur, if you have an astigmatism from 6 to 10 degrees, do you prefer to rotate it or to wait till 2 weeks, then do a refractive corneal procedure?
Yeah, I think so. It depends. I'll always use the eye trace to help me decide where the biggest issue is. If the eye trace is very clear that by rotating it, you can get a very, very good outcome, then I think I'd rather go the rotation route. But the moment you think to yourself, I'm not happy with these zonules necessarily, the patient's older, I'd much rather just go to the surface. You know, whatever you show a patient in a phoropter is what they should get with corneal surgery. If they're happy enough with that, corneal surgery is a very safe option.
Okay, thank you, Dr. Arthur. And thanks for attending. I know you are very busy, but we hope that we will finish with you in the last after this Safwan presentation. Thanks a lot. Now, my dear friends, Dr. Safwan, go ahead, please.
Good evening, everyone. And I think that hopefully that it's good evening and good morning. I think that in States, good morning. So it's nice to participate in this international meeting and webinar meeting. And thanks to my colleague, Dr. Muhammad, to give me this opportunity to present this presentation. My presentation simply, it goes to the spherical calculation in a virgin eye. Because I present this presentation in one webinar, and the questions is that why you didn't mention the post-refractive, why you didn't mention those cases with the irregular cornea. No, it's in a virgin eye, and we need to optimize our spherical calculation in this virgin eye in a way that we can overcome the surprises. And I don't have any financial disclosure. And we will go to, we know that our cataract surgery start to be a refractive surgery, as all our colleagues mentioned. So consider refractive procedure that aim to reduce the spectacle dependence, and the majority of patients with no ocular morbidity achieve unaided driving vision to 6/6 or 20/20. The refractive surprises is the failure to achieve this intended post-operative refractive target. It can cause anisometropia or dominance switch, and is source of patient dissatisfaction due to unmeet expectation. Now, where is the sources of these surprises come from in our routine cataract extraction and calculation? It came usually from the axial length, mostly when the axial length is over 25, actually 26 and above, and below 22. And from the ACD, the AC depth, when it's below 2.5 and above 3.5. And from our keratometric reading, and from some of the formulation, our formula, current formula calculation. Now, if we will go to just return back to ABC, a short review to a third generation. Does anyone using third generation? Well, this question we need to ask to ourselves again, because still we use Hoover Q or Holiday 1 and SRKT, which pretend the effective lens position means that it's not estimating it. Well, we will see from this presentation. Now, as we know that the third formula generates theoretically formula that estimate the effective lens position. The longer the axial length, the steep the K value, the deeper the anterior chamber. This is the theoretical issues in third generation. The shorter the axial length, the flatter the K value, the shallower the anterior chamber. So it's all pretending. Now, fourth generation, that the current that we are using, and the main of it is the Barrett Reverser 2, Haggis, Holiday 2. Were created to better predict of the IOL power. These three formula use different set for constant Haggis 0, 1 and A0 and A1 and A2. Barrett, the lens factor, and Holiday 2 use white to white measure, add to the lens factor. They also consider the preoperative anterior chamber depth, ACD, for better prediction of the effective lens position. And that point, consider the priority of the fourth generation to be used, because it's considering the ACD preoperative. Now, in National Institute for Care Excellence guidelines for IOL calculation, we can see that it's still not specified which formula, which kind of rhythm that we need to use to go through in all our cases. Most modern formula are good at predicting post-operative reduction in standard eye axial length 22 to 26. Still, we are on the same dilemma with the NICE guidelines recommending Barrett Universal 2 or SRKT in short and long eye, where the greater variability primarily due to the postoperative effective lens position. The NICE guidelines recommend using Haggis or Hoover Q if the axial length is less than 22. And here, point that we will I will in detail discuss it. And the Haggis or SRK2T if the axial length is greater than 26. The ray trace software and the Hill RBH calculator also shows promise in improving biometric calculation. Now, in study shows that the effect of anterior chamber depth in choosing of in choosing the intraocular lens calculation formula in patient with a normal axial length, it goes to a conclusion that the Hoover Q formula perform best in short eye with an ACD shallower than 2.5. It actually acts better than Barrett's. And here, this point, it's very important to mention it, because sometimes someone will ask, but how many patients we have with the shallower ACD? Yes, that's right. We have a less percentage with the ACD less than 2.5, but we can consider ourselves that we are implanting a premium lens in those patients, and then we are ending with a plus 0.5 or plus 0.75 if we will use Barrett in those cases. In short and normal eye with ACD less than 2.5, the Haggis formula might, Haggis and the fourth generation Haggis and the Barrett too, underestimate the effective lens position and result in myopic predictive refraction error. On the other hand, the Haggis formula is recommended with its better prediction in effective lens position in eye with an axial length 24 and AC depth more than 3.5. The second study, an improvement on universal theoretical formula for intraocular lens power calculation, they conclude an increase of 1 millimeter in ACD will cause a change in the effective lens position in, for example, Haggis formula or Barrett formula of about 0.4, which will be reflected in a refractive changes of 0.6 to 0.8, which is the author result of the Haggis and Barrett formula, the fourth generation. Now, optimizing intraocular lens power calculation in eye with the axial length above 25. I have an important study that done. One of the author was Thomas Conan. I trust this guy. The following equation was used to transform the axial length value given by the IOL master. So they didn't use that value in those eye where their axial length is above 26. They use a transformed formula to change that axial length according to their study. The transformed axial length equal to axial length that it's been detected by the IOL master plus 1.0848. This is a factor that they discovered. The transformation gave 0 prediction error and 0 steepness of the regression in the fitness. So in conclusion, we propose a method of optimizing axial length in eye with axial length greater than 25. And just allow me to, the performance of the method of optimizing axial length was completable to that of optimizing lens constant, because they compare the modifying the axial length and modifying the lens constant for IOL of 6 diopter or more. For IOL of 5 diopter or less, the best result were obtained with the optimizing axial length formula with the manufacturer lens constant. We recommend caution when using the optimizing axial length formula, as slightly myopic result may occur. ray tracing, calculating the refracted ray at both anterior and posterior surface, avoid the use of average corneal refractive index. The ability of the ray tracing software to be performed over any corneal diameter minimize a potential instrument and thereby radius error. Finally, formula error are avoided as IOL position may be calculated without respect to the any anterior curvature value changes. The result obtained by Savini and co-author in a recent study paper further highlight the potential of the use value based on ray trace principle in calculating IOL. Hofmann suggests that although the predicting accuracy of ray trace remain only comparable to generation formula, the accuracy in abnormal eyes, those with the long or short axial length, and those with the refractive surgery is improved. Personally, I'm using it for those with the higher than 20, their axial length higher than 26. Hill's formula. Hill's is not a formula. It's unlike static theoretical formula. This approach will be an ongoing, so it's still collecting data and showing considerable amount of accuracy coming with the information data that they collect. Will be an ongoing project and continuously updated as big data exercise. The greater the number of surgical outcomes that are fit to RBF module, the greater the overall depth of accuracy. Beginning in January of 2018, the size of RBF calculator database was increased by almost 4 times. In its present form, version 2 of Hill RBF calculator has been optimized from plus 30 diopter to plus 6 diopter for biconvex IOL, and from plus 5 diopter to minus 5 diopter for meniscus design IOL. And this is the RBF, Hill's RBF calculator online, and the issues that I'm using all in all. The summary for all what we are talking. Axial length between 22 and to 26, any formula it fits. And personally, I'm using the Barrett 2 and in this axial length, which gives me the best result. But I'm comparing all formula and comparing all the result of which on all our machine, K reading coming from all machines, and seeing any variation or misalignment in this K, I will change it. And considering here that the axial length, the ACD is within normal limit, which is above than 2.8 and below than 3.5. ACD below 2.5 millimeter. I'm using personally the Hover Q and Hill RBF, but depending on Hover Q more. Now, those that they are not using, not using Hover Q, they are using Hill's or Barrett, they will see that there is some underestimation in about from 0.25 to 0.5, especially in Barrett. ACD above 3.5 millimeter, 4th generation, the Barrett and Haggis and Hill's, it works in a beautiful way, and it's in very accurate way, especially Barrett here. And I'm comparing between Barrett and Hill's here in this axial length. Axial length below 22 with ACD below 2.5, I'm still using Hoover Q and with assistant of Hill's and Barrett, but depending on Hoover Q, whenever the ACD is coming below 2.5. Axial length above 26, as I said, as I show in the old studies that present the transformed axial length formula compared with the Hill's RBF and with the ray trace. So I'm comparing the three, and mostly I've got the best result slightly undercorrecting and undercorrecting in minus 0.5 to minus 0.75 in those formula. Great, thanks. Dr. Muhammad.
Thank you, Dr. Safwan. Thank you very much. Any question from Dr. Yassin, do you have any question for Dr. Safwan? I think it's a very illustrative talk.
That was a great talk. Thank you.
Yeah.
Maybe we need Majdi, we can ask Dr. Arthur if he's having any comment about that. Dr. Arthur wants to run very fast. That's why he don't want to make a comment.
No, I have one comment for Dr. Arthur for his repositioning of the lens. As far as that, I finished quickly. And because Dr. Muhammad, he was pushing me to be on the time. So I'm restricted on the time. So, and I'm afraid from Muhammad, he's my boss. So Arthur, you mentioned a few things related to the repositioning. You know what? Where my problem when I have repositioning, I have it with the young, because all the cases that you present is below 47, and I'm using Barrett with the axis of Barrett. And when I'm using Barrett with its axis, as you know, that Barrett is shifting 20 degrees toward the against the rule. And sometimes, unfortunately, for a reason or another, we are forgetting the age of the patient. And when we are forgetting age of the patient, I had few patients that they have I have to rotate the lens, and their age was 35, one of them, the other one 42, and the lady was 45. And then I realized that when in age below 50, I shouldn't use the axis of Barrett, because everything was correct, but in those age, they are not accepting this shift. So I just returned back 20 degrees, and everything was corrected. I do agree with you that eye trace, it gives you the best, but in those that above 50, and when we are using the total corneal power with their axis, it's hardly to have, unless you have a problem with, as you said, the zonules or the lens is rotated during the surgery. Then, as you said, I will go through and I will do refractive surgery, because I will not rotate their lens because of the zonules. Great, thanks for your nice presentation.
Thank you for all. We have one question. Maybe we can have all of your opinion. How we will calculate intraocular lens power for those patients who undergone PTK? Let me start with Dr. Arthur.
We've undergone PTK. So PTK would normally just give you a more regular cornea, so it shouldn't really impact your calculations at all. PRK, of course, it will, but not PTK.
Yeah,
this is okay.
PTK. I think that there's a wrong with because he mentioned
PKB?
Or he need to mention PRK.
PRK maybe, I think, but it's written here BTK.
And
that's why I read.
PTK gives you a little bit of a hyperopic shift, so it's not really changing a whole lot. So I don't make any adjustments.
So if it is BRK,
if it is PRK, you would go and use one of the formulas to help you calculate the true. We use Barrett True K. We find that really good. The Astros platform has an array of formulas. You just put in the data, and it gives you maybe 4 or 5 different solutions with an average. That also works well. But Barrett True K works very well in those cases.
Yeah, Barrett True K with the net corneal power, it gives the best. And even now we can, in at least semi-regular, let us say that centrally located PRK, and there's no high astigmatism, we can predict. For example, we can targeting the minus 0.5, or we can target minus 0.75, and from this point of view, it's very correct.
Thank you very much. I would like now to ask Dr. Razan to introduce the last speaker, Dr. Razan.
Thank you, Dr. Muhammad. Thank you, distinguished speakers, for what we had. Now we are going to talk about lens-induced presbyopia management, a debatable subject, because Dr. Arthur Cumming will convince us about diffractive lenses, and Dr. Ashraf Armia will convince us about refractive lenses. So let's start with Dr. Arthur Cummings, please.
They are both a friend, but today now we make them enemy, only in these few minutes.
They will convince us.
The truth is, for someone like Ashraf, you cannot make him an enemy, even for 1 minute. He's too much of a good friend.
Thank you.
But I'm going to make a comment for diffractive IOLs. Let's give it a bash. So these are my disclosures. Alcon has a application here because they make diffractive lenses. So just a few facts to consider before we start. The best quality of vision is with a monofocal. And then the greater the depth of focus that we gain with an IOL design, the greater the cost in terms of dysphotopsia. There's a trade-off between quality and range. It's important to speak to the patient. Informed consent is paramount. And Ashraf, I'm here to learn from you. So if you give me better ideas than what I have, I'm happy to learn. But I'm going to tell you why I think diffractive is better. So when we speak to patients about multifocal lenses, we make them very aware of this compromise. And the first thing I say to them is, if you don't want to do a multifocal lens, what you can do is you can do blended vision, one eye for distance, one eye for near. But even with blended vision, we have a compromise. If you had 3 eyes, we could take care of you. One for distance, one for the computer, one for your phone, but you don't have 3 eyes. So whatever you do for the presbyopic patient, there's some level of compromise, and it's important that they understand that. So multifocality, we're splitting light, and that's going to cost us in terms of dysphotopsia. The more complete the range, the more the dysphotopsia. The less glare and halos, the less range you get. So there's always this conflict between presbyopic correcting lenses and what they cost you in terms of visual quality. Also, when I speak to patients about these lenses, I'd say, besides the visual benefit, think about this. The overall safety, driving, no one's going to take your glasses off like a child in the car, this kind of thing. In the home, at work, it reduces risk of falling. It's more comfortable. You have better spatial awareness. Sometimes you look better without glasses. You might feel younger. So the value of multifocal lenses is enormous. It's much, much bigger, and they're very good value. When you compare them to hearing aids and these kinds of things, you'll realize they're very, very good value. So these slides are thanks to Shiraz Daya. I've got some of his opinion too. And it's just looking generally at refractive and diffractive optics. And so the refractive lenses at the moment, the very first lenses were refractive, and they sort of went out of flavor long ago. But more recently, there are lenses like the Oculentis M Plus and the SPL3 from Lenstech that are segmental, and they seem to be a lot more popular and doing quite well. But the Array, and Resume are no longer used for a good reason. And these lenses are basically like bifocals, and they have a segment that's dedicated to near. And with ray tracing, you can beautifully see how the distance vision is on the retina and the near vision's in front of the retina. Now, the diffractive lenses, the trifocal diffractives, the ones that are most commonly used are the Fine Vision, the AT Lisa from Zeiss, and the Panoptics. And I'll just go through some of these very briefly. This is how diffraction works. If these rays coming in, and then they separate into different foci thanks to a difference in the surface that they're striking. So that gives you more than one primary point. So with a fine vision lens, for argument's sake, you land up afterwards not wearing glasses for far, intermediate, or near. And these steps are important. If you look at the lens itself, the narrower the steps, the higher the addition, and the wider the steps, the less the addition. And then if you look at the higher the step is now, so the higher the step, the higher the energy for near vision, and the smaller the step, the higher the energy for far vision. So they give a lot of leeway into how people can work with the design of the lens to achieve certain things. So the same step height over the whole optic surface gives the same energy proportion between far and near, irrespective of pupil size. And you can do a combination of 2 refractive structures. So here's a first refractive structure. It's giving you order 1 is far vision, or order 0 is far vision, order near is a 3.5, and the second order is a +7, which is wasted light. You don't use that light. But if you now enter the design, add the second diffractive structure, this is giving a 175 add, and the second order gives 3.5. And now, when you put them together, you combine the top 2 into this one, you now find that you have the 3.5 enhancing one another. You've lost very little light to +7, and you've got a good trifocal. And you're using all the energy into getting the best for the areas that count. So Shiraz's idea, or his summary of this, is that it's a very complex area. It's a bit of an art form. What does he use? He uses trifocals, or toric trifocals, in 85% of his cases. He uses the crystal lens, or the WIOL, in 10%. and monofocals in 5%. So this is a man with a lot of experience in this space, uses trifocals most of the time. The PanOptix is slightly different. And here you have these generations, you've seen them earlier on. The first type is just one additional power. Then with the more advanced trifocals have a second power, and they would typically give you your intermediate vision at 80. The PanOptix technology is called Enlighten. They're actually 3-step heights. So in real terms, it's actually a quadrifocal, but one of the zones isn't being used. Yeah. And so why this lens is particularly useful is it's recommended, the Safety and Health Administration recommends 60 centimeters for reading on the computer, and that's where this lens has its intermediate. And for someone who's at 80, that arm's length is actually for someone who's 6'8". And so what we're trying to do with all of these treatments is give someone functional vision where they can do most of their things without reaching for glasses. The second thing about the PanOptix, which is interesting, it's less pupil dependent, it's not apodized. And it also loses very little light. Even at a small pupil, it's losing 12% of light. And this is just looking at the different lenses, the 3 trifocals. And I agree with all of them, the overall quality actually is very good. If you see what you're gaining, what you're paying for in terms of dystopsia is quite modest. And here you can see the old Restore, PanOptix, Zeiss, and Physiol. Right, so in conclusion, PanOptix gives a more comfortable near to intermediate range, and it's less dependent on pupil size. And now to make my point, Ashraf, this is the part that's going to stump you, I think. There's a device called the Viveo Lifestyle Match Index. And what it does is it replaces our regular questionnaires with objective measurements. So it measures the patient's own defocus curve, their ambient lighting conditions, and their head position. And then it calculates the defocus curve and gives you a summary of exactly what their needs are. Here's the part I want to use. This part's fascinating. It's called the Lifestyle Match Index. And when you now match the patient's defocus curve to the lenses on the market, the first lens it goes to is a monofocal. And in this case, if this person wears a monofocal, they'll be out of glasses for 21%. This entire unshaded area, they need glasses. Now, if you put a generic bifocal in, you see there's a big gap missing in the middle. That's a +3. If you put a +250 in, it's reduced that gap, but there's still a big gap in the middle. If you put an EDOF in, now it's improved the intermediate. If you're missing something on the reading side, and you put a trifocal in, you suddenly clear that entire range. So we also today have this ability with Viveo that it ranks like a Google ranking. It ranks all the IOLs, including mixing and matching, including monovision, and including targets where you can offset a lens, like a lens like an EDOF, where you want to maybe have one eye planar, one eye minus half. It does that for you, and then does a ranking for you. And Ashraf, in the majority of patients' lifestyles, the trifocal lens is the best lifestyle match fit. There are 25% of cases where an EDOF is a better option, depending on the patient's needs. We also know that when they use this device, patients tend to use a presbyopia correcting IOL because they really understand what the value is. And more often than not, that IOL is a trifocal. So thank you very much, Afrin. I'm keen to hear what you have to say.
Thank you, Dr. Arthur. Let's see Dr. Ashraf.
Yeah,
he's standing for you, Ashraf.
We have few minutes for a comment in a way that I can support Ashraf.
No, let us listen to Ashraf first, then we can see at the end.
Yes. Okay, it's very difficult.
Dr. Razan, you are the one who is moderating now.
To have a debate with Arthur and even talk after Arthur. So I am going to try something. Okay. I'm going to take the words from Arthur, and I will going to divert it not to a debate, to continuing how it will going to be. So I have no financial disclosure regarding my presentation. So the relatively flat growth in the refractive IOL implantation worldwide is indicative of a continuing and challenging that the cataract surgeon face in meeting the refractive goals and expectations. So these challenges make the preoperative counseling time consuming and stressful for both the patient and their ophthalmologist. So if you rushed or ineffective communication risk the increase of post-operative dissatisfaction and chair time. Due to the popularity and availability of the premium intraocular lenses, the main goal of cataract surgery has shifted from sight rehabilitation to restoring vision at as many distance as possible. So, as Arthur said, multifocal can be categorized according to their design as a diffractive lenses, refractive lenses, and lenses involving both diffractive and refractive design. Also, as Arthur said, multifocal refract or diffract or both, it's a favorable as a light from an object simultaneously to far and near vision, and part of this light disperses. But this division of light of different focuses may occur as a result of some combination. Two or more different anterior spherical refractive surfaces, a posterior spherical refractive surface with a multiple anterior aspheric surface, or an anterior spherical refractive surface with a multiple posterior diffractive structural surfaces, or even a biconvex lens with the longitudinal abrasion on the anterior surface. As Arthur mentioned, these are the schematic picture. In the left is the design of the refractive power annular zones, and to the right is the schematic design of the diffractive intraocular lenses, showing different zones that diffract the light, providing focus at different distances. As we all know that the refractive lenses mainly serve for far and less for near and intermediate. In the opposite, the diffraction serves more for near and intermediate and less for far. This is why, because the power red light is less than the green, less than the blue, and the opposite is diffraction. So the diffraction is opposite the refraction in how it communicates. So if you are combining the diffractive, which is mainly for near and intermediate, and the refraction for the far, you are going to have a compensation of the chromatic aberration less and more favorable for the patient. The refractive modules reach the multifocality by their different refractive power annular zones and usually provide a pre-op far and intermediate vision. However, sometimes the near is not sufficient. They are dependent on the pupil dynamics. So this is a problem, very sensitive to their centering. Another problem may cause halos and glare and may reduce the contrast sensitivity, as we are going to see in this slide. So in addition, some refractive designs include a continuous change in the curvature between the zones, providing functional vision across all distances. As Arthur mentioned in the lenses, I'm not going to talk about these because he's already mentioned, but in this table, we are going to compare between old lenses, which is the Oculentis and the M+X. You are going to see how they are giving the near and the asphericity as neutral at everything. But in this table, you are going to see that the Oculent is giving the worst at all distances. But what is the better is not in the extreme pupils. If it's very small or it's very large, it gives you the best. But the Reiner M FLACS, it is making the contrast safety decreases and mainly better for bifocal, which give the better candidate. The main problem in the refractive is the IOL decentration, which affects the visual function depending on the degree of decentration, the IOL design, and the pupil size. So this is a study comparing the performance of 2 diffractive and 2 refractive multifocal IOLs with different levels of decentration in an eye model with a 3 millimeter pupil, found that for a total diffractive structures like the ZM900, both far and near modulation transfer function, which is the MTF, were effective starting at a decentration of 0.75 millimeters. The MTF is an objective metric for the contrast sensitivity, representing loss of the contrast produced by the optic lobe of the eye. Also, the MTF, therefore, has the ability of the lens to display the ratio image contrast to object contrast for ocular optics as a function of its spatial frequency of sinusoidal grading. So, for a diffractive, but with a monofocal peripheral part at the restore +4 IOL, the near MTF decreases as the decentration degree increases, while the far MTF tends to improve. For a refractive IOL studied at the resume and the SFX MV1, the far MTF deteriorates starting at a decentration of 0.5 and 1 millimeter respectively, with no changes for the near MTF even in 1 millimeter decentration. As you all know that the argon laser iodoplasty can help in this. As Arthur said, this is the hybrid refractive and the EDOF lenses with the bifocal technology, the old, and this is the new EDOF IOL, the AcuFocus IC8 was giving the best for the refractive part. And also this is the new hybrid refractive and diffractive IOL, which is at the A, it is the Swiss Advanced Vision Aiding, and at the B is the Vision Harmony, the new one, which is giving the distance and the intermediate and the near, comparing to the Techno Synergy in the right side. Very important as the ACUS is high rising nowadays, there is a confusion in the terminology. The pure EDOF lenses is a lens that has a spherical abrasion increased to elongate the focus, but has no multifocality. In donating that, certain amount of ocular aberrations and increase on the purpose to create a minimal blur necessary to different distances. So the cost of this might degrade the quality of vision. And we believe that the IOL should be named as EDOF lens when it does not have either refractive or a diffractive add multifocal. Very important to know that the EDOF technology can provide more than one diopter range of focus. For example, the Symphony or the Synchrony, Atelier, and the hybrid IOLs, which combine an EDOF with a multifocality. These lenses in the market has growing back, and nearly not anyone going to implant it, neither of them anymore. So the multifocality and the EDOF characteristics are not exclusive for each other. A bifocal IOL may exhibit an EDOF characteristic like otherwise, but the range of vision is partly limited compared to the modern multifocal. Otherwise, the EDOF IOLs could potentially induce less dysphotopic phenomena, as Arthur said, compared with the multifocal. And with further researches, we'll continue toward finding a balance between the quality of vision, the EDOF, and the dysphotopsia. So the question now is it still remain, however, is how we can maximize post-operative vision at all distance with these lenses. Could IOL design can improve, or should more hybrid IOLs be introduced to the market? Or maybe we should consider blended implantation? Counseling and advice are needed to ensure satisfactory outcome for both the patient and the surgeon, and for sure the Viver, as Arthur said, which is a very important device nowadays in choosing the lens. I believe that the EDOF lenses should be used as a monofocal lenses with a minor improvement for near vision. And for multifocal hybrid IOLs, one can reduce the quality of near vision, but keeping the intermediate vision the same quality of the retinal image, but at the same time, you decrease the halos and glare. So this is probably the indication. Also, I believe if the patient requires good near vision with an IOL, we believe that he should receive a multifocal lens, a refractive and a diffractive module, making the choice depending on the patient profile and preferences. It is not an easy task to make a choice of lenses. This is why objective information based on the aberrometry internal component information would be required. And also, I would also important to develop standardized objective means of measuring and reporting visual and refractive outcomes of these lenses. And also, you should inform your patient that the neuroablation is the major concern in the multifocal or EDOF lenses. And the pure EDOF lenses with a relative amount of aberration to improve near vision. So my take-home message after this is there is a wide range of IOL available in the market. A careful and a complete examination of the patient and the IOL selection, which is based on his lifestyle and visual needs, would be recommended. There is a confusion in the terminology. Some of the so-called EDOF lenses available today are really multifocal lenses with a low near-add power, in which part of the rest of the power has been withdrawn to avoid the overlapping of the images and consequent halos and glare by a certain standard of focus caused by the induction of spherical aberration to a certain level. And we propose an alternative terminology and naming lenses that have combined optical designs as a hybrid IOL. Thank you.
Okay. Dr. Razan?
So Arthur is here.
Yeah,
Thank you,
Arthur,
Dr.
I think he sent message. Yeah, Dr. Razan with you. Okay, go ahead. Continue, Dr. Razan. Anything?
No, I said thank you, Dr. Ashraf.
Oh, thank you.
Thank you so much. Thank you so much, Dr. Arthur.
I think Dr. Ashraf, Dr. Arthur, he just said he will go for the patient on a table. I don't know he come back or not.
Yes, just minutes, yes.
Yeah. Dr. Yasin is here. Still Dr. Yasin. Ahmed. So most of them, you know, this is the time of everybody to run away at the end.
Okay.
Anyway, thank you very much for all of dear speakers, also for the moderators, co-moderators for these sessions. It was very interesting. If there is anything, Dr. Razan or Dr. Ani Majdi, to say before we came to conclude these sessions.
It's an excellent session. Thank you for everyone, for Dr. Yasin, for Dr. Ashraf, for everyone. It's an excellent talk. Thank you.
Thank you so
Dr.
much.
Razan.
Thank you.
Thank you so much. It was really helpful. The talk was so nice. We benefit a lot from it.
Okay. Thank you very much, Dr. Ashraf. It was our pleasure to be with us. And we hope to see you again, inshallah. Yeah, nice to meet you. Also, thanks for other speakers. It was really first, we have so many things happened, but it will be solved, and we are solving. There is a lot of people, they cannot join us. Actually, our registration exceeds 2,000 registered, but they cannot connect with some certain of problem of, but Dr. Arthur is coming now. So according to election we have done and voting, I don't know. We want to announce who.
Arthur, for sure.
I really enjoyed your talk, but I had to miss the last 2 minutes, I think. And
yeah,
okay.
Dr. Ahmed is coming back. Okay, no, it was, it's a continuation. It was really at. You are giving some benefit, but I think what I learned from all this one, if you want me, because I'm not that much knowing about this one, but the first slide you show, monofocal, still, this is the last message I can receive from the talks. There is something that we have to wait until we can get, and there is a lot of controversy, which one is better, so which one is going to have refractive, diffractive, focusing more effect. But I think, yeah, the thing is going, and the development is going on, and we can maybe in future have one that can solve all the question it's in our mind. If there is any comment from any one of colleagues here before we can close these sessions.
Only I want to talk to Dr. Ahmed about the femto laser. Yeah. I don't want me to be the bad guy, but I think the normal phaco technique is really nice, and it will not take a long time, and it's less expensive. As you said, I think maybe we need another kind of technology, more easier than the femto laser.
I think so. Also, we have to find a technique that really decrease the phaco energy. Currently, femto can't do that.
Yes, go ahead, Dr. Arthur. Yes.
The point I wanted to make is I'm also not a huge multifocal user, but since we've been using that device that shows the patient what their needs are. They are saying to us, I want a solution. So we're now using it a lot more. And what I'm learning is that patient satisfaction is very, very high. And currently, we're all waiting for the accommodative lens to come out. The problem for the accommodative lens is that these diffractive and refractive lenses are getting so good now that the bar is getting higher and higher for the accommodative lens. So I'm very surprised. And I think someone asked the question earlier, should we to every single patient say you have the option of a toric? I think the day is coming with informed consent that for every patient you treat, you're going to have to tell them, you have the choice of a multifocal. I don't do them, but you have a choice of that. I can send you to someone who does, or if you do them, you have to explain what the issues are. But the value that they give you to allow you to have a freedom of vision without reaching for your glasses is powerful beyond just vision. All those other things I mentioned, not falling, and just having control of your own environment, owning your vision as opposed to having to look for glasses to get it. You can't underestimate it. I think it's going to grow. We've been saying it for a long time, but I think the time has come now with lenses that are so good that we're going to start seeing this segment grow. What do you think, Ashraf?
May I add a sentence?
Okay, we have 2 minutes. We have to close because
in Turkey, there is a big advertisement campaign from one of the big hospital groups saying that these are intelligent lenses. And eye lens, it's so common that even 30 or 20-year-old people is asking me, can I have an intelligent lens? So, but for the over 40 or over 45, it's so common to have these lenses in the eyes of people. And I think Turkey is becoming one of the biggest markets for these lenses. And as you said, 99% of the people are very happy with them, and they are telling to other people, and others are coming for clear lens surgery over 40 or 45.
And yes, I can see that there is no company can provide everything for the lens, and not every patient like the other, and the needs for different patients are different. And according to the needs, you're going to choose the company that fits the needs for the patient, according to the technology of every lens. This is how I can see
it. Thank you very much for, I'm sorry. Thanks a lot for all of you. We hope to see you, inshallah, in future, but we are going to run to the second sessions after 15 minutes. So thank you for all of you, and good night. See you in the next session. Dear participants, we are going to have a refractive session after 15 minutes. We will start, and we are going to have oculoplastic sessions, and we have glaucoma about visual field interpretation. If there is any problem of connection, we will send a direct